Hi, it's Dr. Mann, OBGYN and lifestyle medicine. Today I want to tell a story of myself. It's a famous story. A lot of people know it. It's something that happened to me as a physician 32 years ago. At the time I had a newborn baby. He was 2 months old. And on that morning, I had a scheduled cesarean. It was a woman who had 2 previous cesareans, and she was scheduling her 3rd cesarean. Everything went fine. Got onto the OR table, got her IVs. My anesthesiologist was a wise man, and he put 2 what we call large bore IVs, just in case she needs a blood transfusion. And we laid her down, we draped her, we made the skin incision, we opened the uterus, we delivered a beautiful, healthy baby. Within a few seconds of that, the resident anesthesiologist says to me, "Dr. Mann, we have a flat line." I looked at her. I said, "What are you talking about?" She said, "Dr. Mann, it's a flat line. She's in cardiac arrest." And I said to myself, I don't believe this. What is this? And then I realized that she must have had an amniotic fluid embolism. It's a very, very rare condition where some amniotic fluid escapes into the bloodstream and travels through the circulatory system, and some of this fluid goes in the lungs and it causes a complete cardiovascular collapse. So this woman was in cardiac arrest. Alongside with cardiac arrest, and we know in amniotic fluid embolism, there are substances in the amniotic fluid that cause something called DIC, or disseminated intravascular coagulation, which means that the patient completely loses their ability to clot blood. So we were faced with this cardiac arrest patient, and we started doing CPR. Now, realize in those days, we didn't have all the sophisticated systems that we have nowadays. Call this, call that. We had a code team. There was no massive transfusion protocol. We called the code team, and the residents started doing CPR on her. I had a team of doctors doing a hysterectomy while we were figuring out how to save this woman's life. I called my husband at home to pray. We were trying everything we could possibly think of. There were maybe 30 people in the room. It was more than any TV drama that you have ever seen on any TV show. It was real life. And we're coding her, and she is barely responding. And people were even thinking of giving up on her, but I just could not give up on her. By the way, she wasn't Jewish, she was Italian. And I'm standing there with the code team, just looking at everything and trying to make an assessment. Is there anything we're missing? Is there anything that we could do? And I noticed, of course, the patient was intubated, that the patient was hooked up to the respirator, and it was set on the vent, meaning she was getting air, she was getting oxygen, it was coming in, but it was coming in, let's say, at 18 breaths per minute or whatever they had set it to. And I said to the chief anesthesiologist, there were maybe 6 anesthesiologists there already. I said, listen, take her off the vent and hyperventilate her. Use the embu bag. Maybe if we hyperventilate her, she'll do better. Maybe she'll respond. So he did that. He disconnected her from the machine, and he started bagging her. And within a relatively short period of time, who knows how long, because nobody was thinking anymore, we were just doing anything we could. Within a short period of time, she started to respond. And she started to have some sort of rhythm and a blood pressure. We kept doing CPR. And eventually, we were able to stabilize her. She was bleeding out of every orifice because she was in the DIC, as I explained. She couldn't clot her blood. And we were pouring blood into her, and we had to close her belly. In those days, what did people do? We packed her with lap pads, sponges, towels. We packed her with maybe 20 sponges, and we just closed her. She was oozing blood from everywhere. She barely had a blood pressure, but she was alive. And we took her down to the cardiac cath because we were going to put an aortic balloon pump in her. But miracle of miracles, by the time we got down to the cardiac suite, her blood pressure was high enough so that we were able to avoid putting the aortic balloon pump. So we took her to the surgical ICU. She was very, very unstable for the next couple of days. I actually didn't go home for 4 days. I stayed at her side. I slept in the ICU. We had at that time a babysitter who couldn't figure out why would a mother abandon her 2-month-old child for 4 days straight. But I couldn't leave her bedside because her blood pressure kept drifting down and drifting down and drifting down. We just couldn't get her stabilized. And then I called the senior GYN surgeon. His name is Dr. Kolpatia. He's retired now. The man is an angel. I said, listen, you have to come here and help me. I just can't, we're not keeping her stable. I'm afraid she's going to leave us. He came in and we took her back to the operating room. And we opened her up. And we didn't find any bleeders. And we packed her up again and closed her and sent her back. And we realized what we needed to do was just keep replacing her. And we kept giving her blood and more blood products. And eventually, she stabilized. Eventually, we were able to remove the sedation that she was under. And I spoke to her, and she told me she had an out-of-body experience. And I heard the whole story. And we were so close. We became so close because of what happened. And she told me all the details, and all the details match what you hear about when you hear about out-of-body experiences. But the interesting thing was that after about a week, she had forgotten all of that. It just left her. She spent a month in the hospital. At the end of the month, she had gotten about 60 units of everything. And she was stable enough to walk out of the hospital. It was a miracle. And we had a party for her. I'm not going to tell you her name because there's no reason to. After that event, it changed me forever. First of all, I had so much gratitude for all the doctors in the hospital who helped me that I said to myself, I don't need to go to a Manhattan hospital. I have everything here in my hospital in Brooklyn. Everybody rose to the occasion. We saved her life. That was the first thing. And the second thing was that I became obsessed with helping out in code situations. Whenever there was a code, my patient, another patient, it didn't matter to me. I showed up at every code. Why? Because I learned that there might be something more that you could do to help the patient to improve the outcome. And if I'm there, maybe they didn't see it. Maybe they didn't see it, and maybe I'll see it. And I would do anything for anyone. They want me to hang blood, fine. They want me to stay with their patient while they're in getting some embolization for some uncontrolled bleeding, fine. I will go anywhere to any code. And I've kept that up to this very day. And it's helped me a lot. It's helped me to become a better doctor. But also, I feel like I have to give back for what I received. And the last thing was that I became obsessed with cesareans because the number one risk factor for an amniotic fluid embolism is cesarean section. And I realized people don't realize women die from cesareans. And I started to study cesareans, and I started to study vaginal birth. What's the difference between an obstructed labor and a dysfunctional labor. Dysfunctional labors are common. We think, oh yeah, I'm in labor, I'm gonna come in, I'm open 5, by the time I get to the room I'm 7, and then another hour or 2 later they break my water and I start pushing, the baby comes out. Yeah, there are some labors like that, and then there are labors that just go on and on and on, and there's very little progress, and the woman is in unbearable pain. Or they get an epidural and they're just laying there and there's no motion, and the baby cannot negotiate the pelvis properly. And so there's so many reasons for dysfunctional labor. But then there's another category called an obstructed labor. An obstructed labor means that no matter what you do, no matter what maneuver you do, the baby's not going to be born vaginally. And if you don't do a cesarean, the baby's going to die and the mother's going to die. So I've spent my career trying to distinguish between dysfunctional labors and obstructed labors, because I believe that women should not have a cesarean for a dysfunctional labor. They should allow the body to correct itself or intervene and manage them and get them delivered. Because the worst thing of all is to say, because you had a cesarean, that you're risking your life. I know women don't want cesareans because they think it's not nice and it's not good for them and it's an invasion of their integrity and they want to have a good birth experience and all of that. Never mind all of that. It's life-threatening. On the other hand, if the labor is truly obstructed and the baby is not going to be born, you have to do the cesarean. So in 1985, when I started my residency, the cesarean rate was approximately 6%. Now, in the United States, it's about 30%. Women were not created to have a 30% need for cesareans. There's something wrong. There are too many cesareans being done. What can you do to try to reduce your risk of having a cesarean? Be healthy. That's it. Be healthy. Don't gain too much weight. Don't have an excessively big baby. Get a labor coach. Stay out of bed as long as possible. Don't be afraid to let the epidural wear off during pushing. Allow your doctor to intervene and try to correct a dysfunctional labor when it's appropriate to do so. But if the doctor says to you it's obstructed, then we have to acknowledge that a cesarean is life-saving. I want you to know that my cesarean rate is the same as it was in 1985. That's the right number of cesareans. So why am I telling you all of this? I'm telling you all because as physicians, we deal with life and death. And it's very much what we call the second victim, meaning these things affect us so deeply, and it affects our career so deeply, and how we relate to patients so permanently, that to this very day, 32 years later, I'm still having flashbacks. And I remember the residents doing CPR on my patient, and I remember the residents getting fatigued and the next resident taking over, and how heroic all of that was. And it hurts me because right now everything is about the business of medicine. But medicine really, essentially, is not a business. It's a calling, it's a service to mankind. I hope that this was interesting for you. I hope that you will take steps to try to reduce your chances of having a cesarean, acknowledging that sometimes it's extremely necessary. And I pray that the American College of Obstetrics and Gynecology will become more enlightened and realize that we really have to do everything we can to avoid unnecessary cesareans. One of the things that they've done, the American College of OBGYN, is they have designed this so-called hospitalist model. And they're showing that if they have a doctor assigned to labor and delivery, that the incidence of cesareans is lower compared to a doctor who works in the office and also delivers their patient in the hospital, because the doctors are being pulled in every direction. In other words, a shift worker who's an expert in managing labor and delivery is superior in terms of cesarean rates compared to the private practitioner who's running around, his phone is ringing, he's trying to manage people in labor, the office is calling him, etc., etc. And that might be true, but I just want to say one thing, which is the old-timers were really the best. They knew how to take care of women with their hands. There's a certain amount of lost art in the world of OBGYN, and it may actually pay to look more to this hospitalist model. But if you have an old-timer who could do it all, like the people that I learned from and my generation, it's still, in my opinion, superior to the hospitalist model, except we're sort of being phased out. So I think that when the average woman is deciding what type of total obstetrical care she's looking for, if she's low risk, she should probably look for a midwife. High risk is a different story. But I believe in this day and age that what we need is patience. And if we will be patient, we will wait and the women will deliver vaginally. My old chairman, Dr. Minkoff, used to say, when we had 3 operating rooms in labor and delivery, the C-section rate was higher. And when we closed one of the ORs and we only had 2 operating rooms, suddenly the cesarean rate went down. Why is that? Why is there a study that on Friday afternoons the rates of cesareans go up compared to the other days of the week? What's really going on? We have to be true to ourselves. For example, I learned a long time ago that when I was on call, I would never be on call in the morning and then go to the office in the afternoon, because I would feel pressure to go to the office. I would be on call 24 hours, completely focused and dedicated to my patients, and my partners would have to deal with everything in the office. And then the next day I would be off. And that's ideal, because you could focus completely in labor and delivery and not worry about anything else, and not worry about having to go to the office the next day. So these are some of my thoughts. And finally, I'm going to end with one other comment in terms of facilitating vaginal births. And it could be that I made a video about this on previous occasions, but I believe that the American College of OBGYN is making a mistake in not encouraging episiotomies when appropriate, and even something called fundal pressure is discouraged, if not forbidden. What does fundal pressure mean? Fundal pressure means that someone comes when you're pushing and you're exhausted and you just can't get the baby out, and they literally push on the top of the uterus. They push the baby out. They help you push from above. They push on the fundus. That was taken away from us. Now, you might say, oh, that's terrible, it's terrible. My first baby was born with fundal pressure. A big, strong anesthesiologist would come. That was usually who did it, because anesthesiologists have a cushy life and they would go to the gym a lot. And anesthesiologists would come and go like that, on the fundus, and the baby will be born. Great. And the other is episiotomy. Now, episiotomies facilitate vaginal birth, and especially in young women who were not sexually active before marriage, who do not use birth control, and they're 20 years old and they're having a baby, and their vagina is not maximally stretched because it hasn't been used all that much. An episiotomy can facilitate vaginal birth. And it can also prevent very deep lacerations, which are called sulcus tears, which cause a young woman to lose a lot of blood and become very, very weak. In the old days, we would just transfuse these women. But now we don't. We give them iron. But they're like dish rags. They go home, first baby, new mother, trying to establish nursing, weak as anything, because the American College of OBGYN decided episiotomies are bad. I'm sorry, it's misplaced feminism, and it's prejudicial against young virginal women who get married who don't want to use birth control when they first get married. So I think this is misplaced feminism. I think it's an agenda. I think it's a bad agenda. And I believe that if episiotomies were encouraged and fundal pressure would come back, our cesarean rate would go down. And I've seen it happen in my own labor and delivery. I'm sitting around, I overhear things. I hear a junior attending saying, the baby's just not coming out. And I go in there and I say, listen, all she needs is an episiotomy. You put the vacuum on, I'll give a drop of fundal, and the baby will be born. And I'll get a letter in my box for doing an episiotomy, and I'll be cited for doing fundal pressure, but I won't be criticized for taking her to the OR for a cesarean. It shows you it's messed up. It's very, very messed up. These old-fashioned things that the old-fashioned OBs did, they did them for a reason, because it works, gets the baby out. Why can't we keep using them? Well, guess what? We can't. And that's one of the reasons why the cesarean section rate is higher. So it's a very big problem. It's a very, very big problem that I don't see a solution to, except to get a midwife and take care of yourself and be as healthy and as active as you possibly can. I might get into trouble for saying this, that I believe that episiotomies should be used. If they need it, they need it, and if they don't, they don't. And no one should be penalized. No doctor should be penalized and get letters in their box when they do an episiotomy to facilitate vaginal birth. It's completely absurd. So I'm going to come full circle and just summarize. I had a patient who had a cardiac arrest due to an amniotic fluid embolism. A risk factor for amniotic fluid embolism is cesarean. It's the number one risk factor. Amniotic fluid embolisms in general have an 80% mortality. One of the reasons why my patient might have survived is because she was already on the OR table when she arrested, and so resuscitation measures were readily available. My advice to everyone is to try to avoid a cesarean as best you can, recognizing that in an obstructed labor, a cesarean is life-saving for the baby and the mother. In fact, not to ramble on, but I can tell another story. I have a lot of stories I could tell. But I had one time a patient transferred in from the birthing center, and she was having a truly obstructed labor. She was fully dilated for hours, and she kept refusing a cesarean. And they called me to come in and try to convince her, because they know, since I don't do cesareans as a rule, if I tell someone they need a cesarean, it means they need a cesarean. I go in, I examine the patient, and this woman was like a very interesting character. She probably belonged to some sort of a cult. I don't want to get into the details. She had a whole entourage with her. And I said, listen, if you don't do a cesarean, your baby's going to die, and you're going to die. And that's it. It took her another 2 hours. She finally agreed to a cesarean. So I hope that you were able to sit through this 25 minutes of soliloquy, and there will be more stories coming. And I want you to know that the trauma of what I went through that day and the flashbacks, still, they never left me. They're damped down, but they never left. And anyone, whoever wants to hear the story, I will always tell it to them. Thank you all for listening.